Several years ago, the Hospital Association was in a situation where our former president retired, and we were looking for a new leader of our hospital association. And many of you had the opportunity to meet Dr. Don Williamson, who's seated here at the second table. But I wanted to just say in front of him and all of you, if you have not noticed his engagement on quality, patient safety, infections, he attends many of our quality task force meetings. He's attended our subcommittee on opioid task force, and he is here all day today, unless he has to leave, and I didn't ask him that. But that is pretty unusual engagement for an executive of his talent and the demand on his schedule. And I think all of you who I know have the same passion about quality and patient safety. I think it's nice for us to have a leader of our association who believes so strongly in that. And he brings that over with him of having done a lot of the work when he was leader of the Department of Public Health. And the infection reporting bill that many of you are intimately aware of was basically crafted with the support and working relationship with Dr. Williamson back in those days. And who would have ever thought we would have him leading our hospital association? So Dr. Williamson, I just want to say thank you for your commitment on all of this. All right, speaking of infection, or the lack thereof, whatever it is that we wish to have. Obviously, antibiotic stewardship plays a key role in that, and we are thrilled to have the next couple of presentations focused on the areas of infection prevention and making sure that we have good antibiotic stewardship and good training and good efforts in our organizations. So we're delighted today to have our next speaker talking about antibiotic stewardship in the acute care, Dr. Scott Fridkin. He is going to be here as a speaker, as the acting professor from the Department of Medicine Epidemiology at Emory University. He's also an attending physician with the Atlanta Veterans Medical Center and is the director of the Antimicrobial Stewardship Research Program at Emory. He's board certified in internal medicine and is a national leader in epidemiology and antimicrobial resistance. Obviously, we are thrilled to have him and his expertise that he'll be able to bring to us today. So with that, Dr. Scott Fridkin.
Thank you very much. Let me just load these up real quick. So I'm really happy to be here. I have probably not met any of you before, and that's my loss. I come from a background of public health. I worked for 22 years at CDC and the Division of Healthcare Quality Promotion, formerly the Hospital Infections Program. So I earned my chops on investigating outbreaks, learning how to do infection prevention, and spent a lot of time on surveillance. And those of you familiar, you're almost all familiar with the National Healthcare Safety Network. I'm to blame for a lot of that. So I apologize. Part of the reason I've left CDC perhaps is I wanted to move away from that a little bit. And I have been thrust into the hospital system. Emory Healthcare has 4 acute care hospitals, an orthopedics hospital, about 100 to 150 providers in an ambulatory care clinic. And I started just showing up to the quality meetings, the acceleration teams to try to reduce all of that, the NHSN defined HAIs, and I just became fascinated after the first meeting at the intensity and the organization of the quality office, and so I'm sort of humbled by all the work you all do. It's a whole part of infection prevention I just was oblivious to for decades, or 20 years or so. But what's really clear is this tension between the limited resources that really you all can muster with all of this stuff you're trying to take on. That it's just mind-boggling to me that some patient care activities and patient safety activities just are the right thing to do, but yet there's so much you're trying to tackle. You have to really juggle these resources, and I've been really struggling with figuring out how to convince our quality office that some of the investments in stewardship are really worthwhile and will pay dividends, and above and beyond just the cost saving of the formulary. So I thought I'd try to spend this time describing the context of the stewardship program acceleration in general, why there's so much emphasis here, and make sure we're all sort of on the same page, and where it intersects with some of the acute care quality concerns. So just bringing it back down to sort of the patient, and I see this as a recurrent theme, and I'll bring it up again towards the end, is, from their perspective, that's what quality is all about. But this is a really common scenario, and again, this recurring theme about patients leaving the hospital. This is a patient admitted with dementia and arthritis. Baseline function was okay, diagnosed with a pelvic fracture. Orthopedics wanted some conservative management, and went to rehabilitation after leaving the acute care facility. At the acute care facility, the post-acute care facility on day 10, the daughter's concerned about foul-smelling urine. It's dark urine. The CNA documents that the vital signs are normal, no other real change except for maybe a little bit more confused. The daughter requests a urinalysis, and now the staff's calling up the on-call doctor over the weekend. So they order a UA and a culture. And as those are sort of brewing, after 2 days, the provider notes a positive urine culture, but the patient actually by now is actually stable with no fever or urinary symptoms, and the mental status improved with hydration. So very easily in this scenario, and more often than not, that patient would have gotten some antibiotics. Those antibiotics would have put that patient at 8 to 10-fold higher risk for getting Clostridium difficile infection, and a 4 to 8-fold higher risk of becoming colonized with an antibiotic-resistant organism in their GI tract, and those organisms, will be coming back to your acute care facility and be having an impact and potential for spread there. So this loop between post-acute care and acute care clearly is a recurring theme with you all, and I think that makes the stewardship effort and the outreach we need to do with affiliated settings outside acute care very relevant. So this momentum around stewardship, so it's not foreign to you all. The concept, the right drug for the right bug at the right time, the right dose, we're just trying to get it right, it all makes sense. But antibiotic prescribing is complicated, and patient care is complicated. And how these programs should look was very varied. And what CDC tried to do, and this happened while I was still there, we started this process, was to develop what the framework or the building blocks of a stewardship program should look like. So there's some more standardization, but the devil's in the details, and let's not sort of get into the details. Let's just have these high-reaching core components. So this exists now. Core components for acute care, skilled nursing facilities, core components for outpatient antibiotic stewardship, for critical access hospitals. So there's these documents, and AHRQ has put out some toolkits to help facilities get started with stewardship. So this momentum, that I think that the framework helped overcome the inertia of building stewardship. Clearly, the momentum really accelerated with federal incentives and policy. After the core components, CMS funded the hospital improvement innovation networks to help implement and assess stewardship programs. AHRQ has incorporated stewardship into its comprehensive unit-based safety program. And then probably most critically is the Joint Commission took on stewardship as a standard, and now requires there to be evidence of a stewardship program during their accreditation visits. The Medicare Beneficiary Quality Improvement Project, which is a quality initiative for critical access hospitals, has a little bit of a longer time frame for assessing implementation of stewardship. So I think these federal programs adopting stewardship as a must-have clearly is the momentum, or the fuel behind this momentum. But exactly what the assessments are really is varied, and I had a little bit of firsthand experience with this. We knew when Joint Commission was creating the standard, and they described it similar to what was in the core components. They actually misinterpreted a few of the things a little bit, or there's like supporting documents that led people to believe something was different than it was. So exactly how the Joint Commission goes facility to facility to assess compliance is a little bit of a work in progress, or it's a lot of work in progress. And I'm not a part of these discussions anymore, but my colleagues at CDC are still in discussions with trying to help standardize that process and come to some agreement amongst sort of experts and experienced folks about what might be a reasonable approach for the Joint Commission's assessment. Like initially there was this confusion about patient education for inpatient stewardship, and it was felt to be, the hospital epidemiologists were like, that's just really going to be hard to do, and it's not really that relevant. And so finally, Joint Commission did take that out. There's also this one issue about that's been a little bit lost in translation about what's the activity the stewardship program needs to be doing at the hospital. And everyone was talking about this antibiotic timeout, this term, antibiotic timeout. And it's because that was an example that we used at CDC as one example of an action, which is to have maybe during the daily huddle or some other either electronic-based or non-electronic-based pause in a patient's care time to say, do they still need this antibiotic or not? But at some of the initial visits, people were looking for the antibiotic timeout as the action, and it doesn't need to be at all. In fact, the efficacy of that approach to decreasing unnecessary antibiotic use is still in question a little bit. Coincidentally at Emory, I wasn't even aware of it, but over the past, I think about 18 months, this sort of antibiotic timeout has gone from sort of this manual daily huddle in particular locations at one of the 4 hospitals to now occurring across 4 hospitals, but in a very haphazard way at which units are adopting it. But it seems to be sort of a natural evolution. So I think Joint Commission's still learning about what the minimum and outstanding programs are going to look like. And I think the data is still absent about what's a best performing program, what should the best program look like. But we are learning some things about the stewardship programs. For one, more hospitals are fulfilling all of these core components. Now, these are data from the National Healthcare Safety Network. Your hospitals all have to fill out a survey once a year. And that survey gets longer and it gets longer. And the questions sometimes don't seem to make sense. But one of the questions that was added 3 years ago was about these core components. And some may question the validity of the self-reports on here, but there's been a couple attempts at some validations. I think Vizient has tried to do this with some of their facilities. But the proportion of general acute cure hospitals listed here on the left side, I guess, or your right side, is increased over the past 3 years. About 70% of facilities have self-reported they have all the required core elements of a stewardship program. For critical access hospitals, they're lagging a little bit more. And you can split this data up several ways, and teaching hospitals tend to be more compliant, and larger hospitals tend to be more compliant. These data are actually available on the CDC's Antibiotic Resistant Patient Safety Atlas. I'm skipping that one. The Antibiotic Resistant Patient Safety Atlas, here's a picture of what you can pull up from there. So Alabama's pretty good at 64% of all acute care hospitals. That lumps together critical access and non-critical access. And so you can sort of track this if CDC continues to update this every year at least. But this is a nice sort of reflection to sort of see where you may be compared to other states. So some progress is being made with the main elements of antibiotic stewardship program. But the details of what is happening is, like I said, very variable and not documented and not part of these surveys at all. And as I've been at Emory now for a year, and I think Emory Healthcare is great. I'm impressed, and I'm also getting a sense about how complicated the business of healthcare is. But I was really shocked at the difference between the approach to stewardship activities that was being taken. And I sort of lumped these into proactive stewardship activities and reactive stewardship activities. And I'll give you some examples of what Emory does, but I wasn't sure if anyone in the audience here that has somewhat engaged with stewardship may have some ideas about what might be their facilities doing that's proactive. Anybody? So examples of this might be like, just like you're trying to do with the readmissions, determining, well, where's the most unnecessary antibiotic use, and let's change a guideline, or let's change the electronic health record to have a pop-up to warn people not to do something. Reactive is, I think, the day-to-day activity that the antibiotic stewards work on. So this is a list of the standards, the Joint Commission standards for stewardship that our hospital epidemiologist or assistant hospital epidemiologist put together for their Joint Commission visit. And so she put documents together that outline the audit and feedback of antibiotic prescribing that the pharmacists do with the clinician, the front-end clinician. That was number one. And that was what I would call a reactive activity. So they're reacting to a specific prescription. And they have Theradoc. You guys, a lot of people here have MedMind, I guess. But there's these flags that occur when there's a mismatch of a drug and a bug, or a drug at a particular dose, that the pharmacist spends a huge amount of time reacting to specific antibiotics. And these are real patient safety issues, clearly. But it's this incredible proportion of the pharmacist's time to do this sort of audit and feedback. And the audit and feedback, it affects different clinicians to different degrees. There's not a ongoing sort of prospective, we're trying to educate everyone about stopping a certain drug or behaving in a certain way. It's really sort of that curbside consultation, you need to sort of fix this is a problem. And that was the vast majority of their time. The other thing that was a surprise to me, I was oblivious to, is down at the bottom, the antibiotic shortages. So another reactive activity. I thought this might occur once every couple of years, but it seems to be, a monthly or quarterly activity with the supply chain for particular antibiotics and needing to sort of reshape the power plans within the Cerner system about what different physicians should be prescribing. So these reactive activities, the other one is emergency department blood culture follow-up, where patients are going home with positive blood cultures unbeknownst to the providers, and there's no great follow-up there, sort of filling that gap. Something I don't think a clinical pharmacist needs to be spending their time doing. I mean, clinical pharmacists should be helping doctors prescribe the right drug at the right time, the right dose. So proactive things that the Joint Commission was happy to see was a fluoroquinolone use reduction activity, where we're just taking them out of the power plans and we're trying to eliminate their use when there's a comparable non-fluoroquinolone option. And this is because we have a lot of Clostridium difficile at Emory. An active penicillin skin testing program, trying to get rid of and delabel patients as penicillin allergic so that we don't have to use so much quinolones. We can go back to using beta-lactams. And then another one is provider-specific feedback that I'll get to a little bit with the outpatient setting. But these proactive activities, I'm not going to say they're afterthoughts, but there's very little dedicated time allowed to sort of do this. But yet, I think those are the things that are really going to have a longer-term impact on changing the way antibiotics are prescribed and making patients safer. So in terms of these proactive activities, what's needed is an infrastructure to get these metrics and these measurements. And I know that next door I saw a couple of screenshots really quickly from MedMind that they have a system in place to look at days of therapy per 1,000 patient days, or I'm not sure if they use another denominator called days present. But this has become the standard, days of therapy per 1,000 patient days. And a part of the reason it's become the standard is that is what NHSN has as their requirement. I know you got people that attended last year heard a little bit about the NHSN antibiotic use option. So I'll say two things about the NHSN antibiotic use option. It's a good thing, but it's, I'll say more than two things. It's a good thing, okay. Officially, 600 hospitals have contributed some data to that, but that doesn't mean they're continuing to contribute data. A lot have gone in and have stopped, and the reason for that is their information systems or the hospital's information systems may have changed. So there's an issue with being able to continue to report when you guys all make different decisions about which systems to move in or move out of. But for internal benchmarking, I don't think you need to worry about NHSN. I mean, I think the MedMine approach, or if you have your own system and you're looking at days of therapy, 1,000 patient days, just looking at it historically within your hospital, there's a huge amount of insight you can gather. But for this external benchmarking, we're still in the infancy. The NHSN system is attempting to do risk-adjusted benchmarks, but they're barely risk-adjusted. And even the actionable, metric is still an area we're still exploring the value of that and how to go ahead and navigate what those metrics are. So the next couple slides just illustrate the issue around metrics. And like I say, we're in our infancy, and hopefully we're not anywhere near a performance measurement yet for antibiotic use, but these are the reasons why performance measurement or antibiotic use is going to be so challenging. To have a good performance measure on antibiotic use, I think we really need it to be, electronically derived and incredibly reproducible across healthcare systems using different, EMR systems or different EHRs. It's got to be clinically meaningful. Days of therapy is understandable, but there's probably some other measurements too that can be electronically derived that might have meaning to the clinician. If they become so abstract that the clinician doesn't really believe it, it's going to be hard to change their prescribing behavior. I think we have to illustrate that these measures are reactive to better prescribing. If we go and educate and get people to prescribe better and these measures don't change, then there's no point. And I think I talked about being credible, meaning it's risk adjusted, that facilities with big transplant centers and a lot of really complicated, very sick patients that need a lot of broad spectrum antibiotics are appropriately risk adjusted to smaller hospitals that are mostly battling maybe community-acquired pneumonia. And then cons, I think any manual interpretation of data is a real problem. I think they're really helpful for internal purposes, and you don't really need to worry about risk adjustment that much. But I think if there's manual abstraction or manual interpretation, you can't really be comparing it across institutions. And the big con is if you have a measure that doesn't respond to better practice, that's not called a performance measurement then. So the NHSN, these are data from N.E. Stenheim, who is a former Emory ID faculty who's now in Intermountain Health. And he shared this slide which illustrates what one might be able to get at from NHSN they currently do. And these are small screens, so let's just look at the shape and not the details. So the top graph is all the hospitals in their Intermountain Health system. So however many that is, 15 or so. And you're able to look at all the antibiotics, and there's risk adjustment models that NHSN puts out to be able to calculate observed to expected days of therapy, just like there are SIRs with C. difficile or CLABSI or SSI. And Eddie then points to this hospital that's got an elevated, this hospital here, the arrow, that's got an elevated O to E ratio, but you don't really know what the problem is or if there is a problem with that hospital. So it's blown up down here. This is the O to E ratio for different antibiotic groups at that one hospital. And so they're pretty close to 1 for this group of antibiotics in particular patient location. Below 1 here, above 1 here, below 1 here, and then they're really above 1 for just that surgical prophylaxis antibiotics. So it took a little bit of digging to figure out where the problem is, and this is an example that was fairly straightforward that their elevated SIR way up here, observed to expected ratio, is probably being driven by just their surgical prophylaxis. So I think this approach makes a lot of sense. The question, I think, is how generalizable is this? How many facilities can actually contribute to this? And also, is it risk adjusted enough? He's finding it very useful for his group of small hospitals throughout Utah. So there's other potential metrics besides days of therapy. I'm not telling any of you to go out and do this. I think what I'm saying is if you're going to be on the forefront of looking at electronically derived antibiotic use measures, there's some other exploratory work going on that you could become engaged with. DASON is out of North Carolina, the Duke Antimicrobial Stewardship Outreach Network. It's their sister to the Duke Infection Control Outreach Network. And so they provide a lot of consultative services to hospitals around Duke. North Carolina, South Carolina. They even have a few right in my own neighborhood in Georgia. So they were paid by CDC to do some work to assess how feasible some additional metrics are around antibiotics. And I was really attracted to a couple here, metrics that were both useful and feasible. They've highlighted in this reprint that's in your handouts here. And so we talked about days of therapy per 1,000 patient days or per 1,000 days present. There's a few other issues that related to C. difficile that are important. But there's one I want to point to on the next page that is 2 pages that's intriguing, which is this concept of de-escalation. The clinical pharmacists often look to try to de-escalate, and they might do that during the daily huddle. And it's still not that well defined what we mean by de-escalation. I mean, conceptually, it means you're going from a broad agent to a narrower agent when the culture results are back, a more targeted approach. But there's still some subjectivity in interpreting, is this really a less broad agent or not? And maybe you've gone from one broad spectrum agent to 2 narrow spectrum agents. And is that really considered de-escalation? So they've explored this concept of counting the number of antibiotics that occur during a certain interval of a patient's stay. And if that number's gone down, that's a good thing. They go from 2 to 1 or 3 to 1. But then also the spectrum of antibiotic, if it's gone from broad to narrow, that's good. And so they try to combine these two concepts and say, electronically, let's just capture patients, where's my mouse here? Let's try to capture during critical time period of their hospitalization. And if their number of antibiotics goes down from higher to same or lower, we're going to give them a green light and say they de-escalated. And if they're, I'm sorry, that's the ranking of antibiotics. Let's do the number here. Fewer antibiotics versus more antibiotics. If you go from to fewer antibiotics, you end up getting a green light for some de-escalation. And if the spectrum of the antibiotics goes from high spectrum to lower, you get a green light. So you sort of combine going from broad to narrow and from more to fewer to getting an indication for de-escalation. So every patient that comes in the hospital electronically, you might be able to capture if they were de-escalated or if they escalated or if there was no change. I'm not saying this is the be-all and end-all of any stewardship measure, but it's yet something besides days of therapy that we might be able to hang our hat on and say, okay, here's a metric, and now we have to see if it's responsive to some proactive stewardship activity to say, okay, this is something we can track over time. So, like I said, I think the metrics are in their infancy, apart from the day-to-day work that a stewardship pharmacist might do. And I think over the next couple of years, hopefully we'll have some good science in this area to say, this is what we sort of want to hang our hat on. So I also became, I've always been aware about the importance of stewardship in the outpatient setting, but I've also always felt that it was more the domain of the public health department or the private practitioners or the insurance companies, and I didn't fully appreciate the links between ambulatory care and the inpatient setting until coming to Emory. And as I was leaving CDC, we started to look at data around antimicrobial prescribing in the outpatient setting, looking at actual data that was purchased from IMS. And this was a map that also is on that patient safety atlas if anyone's ever interested in looking at state level data. And this is the regional variation in antibiotic prescribing across all these different states. And you can see it's dark in the southeast there, where we tend to have the highest prescribing per capita compared to elsewhere in the country, especially compared to Alaska. Huge difference. There's a lot of unnecessary use in outpatient prescribing, especially among respiratory conditions. Some dedicated efforts have found that about 30% of outpatient antibiotic prescriptions overall are unnecessary. It's a little easier to do this in the outpatient setting than the inpatient. There's often a mismatch between the recommended antibiotic and the one prescribed, so that may not be unnecessary, that may be poor choice. Nearly half of patients do not receive the first line antibiotic for what they should be getting. And then the most common cause of drug-related emergency department visits are related to antibiotics. Some of this is for C. difficile, but probably more of it's for allergies. So stewardship in the outpatient setting does work. And to me, I always thought this seemed kind of simple, but now I understand with implementation science that it's not always that easy to implement a recommended practice just because there's a research paper that shows it's helpful. So with outpatient prescribing practices, just show that varies greatly. And some dedicated studies have shown that it varies across provider types and professional setting. We have the ability in the outpatient setting to sort of look at visits and categorize them as antibiotic inappropriate or antibiotic appropriate or possibly appropriate. And in fact, I'm not sure why they were there, but these were out in the hallway. Be antibiotic aware. There's a bunch of them. And there's this list here of conditions that if antibiotics are indicated, yes, maybe, or no. So you can take all these no's and call them antibiotic inappropriate. And these are the two maybes, like sinus infection, middle ear infection, are a maybe. And some researchers lump them in with inappropriate and some keep them separate. But you can do this with your own data if you have access to your ambulatory care data. And we went ahead and did this. In this study, I guess I'll get to the Meeker study in a minute, we're able to do that and categorize how often physicians are prescribing antibiotics for inappropriate diagnoses. 46% received an antibiotic in urgent care for antibiotic inappropriate respiratory diagnoses compared to 25% in emergency departments, 17% in offices, and 14% in retail clinics. I think the retail clinics are like CVS. The drivers for better practice have really accelerated in the outpatient setting as well. The Joint Commission's developing new accreditation standards requiring outpatient stewardship programs, and then private payers are also trying to provide some type of stewardship activities, like Aetna, at least in the Atlanta area, are trying to use audit and feedback intervention in their ambulatory settings, and Anthem is providing incentives to providers to implement some stewardship. So with Emory Healthcare, we've explored how varied that prescribing rate is for antibiotic inappropriate diagnoses. And so here on the horizontal axis and these blue bars is just the number of encounters, the number of outpatient encounters that any one provider had. And there's 100 here, it's about 100, that have had at least 10 visits during a calendar year. We got rid of a lot of the residents and house staff and left this with the providers in the main clinics. And so this person over here sees a lot of patients, so 1,000 patients. And then we calculated the proportion of encounters that they prescribed an antibiotic for, a proportion of antibiotic inappropriate encounters. And you can see it's all over the board, going from, this is about 10% or 20% of encounters, up to, 70, 80, 90%. So I think I have a slide with circles. So my colleague, the director of stewardship, the medical director of stewardship at the Emory University Hospital, and the quality lead for the ambulatory clinic, they don't care about my risk adjustment stuff. They're like, look, this should be 0. These guys are prescribing really high rates, and they're at the far end of the spectrum for having a lot of patients. So they have a big denominator. They shouldn't be anywhere up there. And there's people that have similar numbers of patients that are way down there. That's just, doesn't make sense. And likewise, you have people with very few patients that are prescribing almost all the time, and that doesn't make sense either. So we've actually gone ahead and analyzed these data because I want to do risk adjustment. And yeah, age predicts getting a prescription, and comorbid illness does. But you look at the people up at this end and that end, and they have just as frequently people over 65 and people with comorbid illness as the people on the other end. So they're right, it doesn't really make a difference, and that's a work in progress. But the interventions is where they're going to now, and there's been a lot of work in the outpatient settings to improve prescribing. There's this nudge approach, which I kind of like this concept of behavioral nudge to make the right choice. and this was published in JAMA Internal Medicine recently, that just basically placing posters in exam rooms with clinical pictures and a commitment to use antibiotics appropriately can really influence the physician-provider interaction, sort of this behavioral nudge to make the right choice. So just that passive thing of having a commitment letter with your doctor's picture on it and a signature and posters, and here's the posters that are available, publicly, apparently makes a difference. And so this kind of behavioral nudge is, I think, building up some momentum and is a very attractive piece. There's also private shaming. There's public shaming that you're all familiar with Hospital Compare, but there's private shaming too, which is this peer comparison. And I just heard this in the opioid lecture as well. And I think this has been really helpful in the outpatient setting, and it's building up steam. And I wish we could do this in the inpatient setting, but the way our hospital system's set up, I don't think we were going to be able to get there. But Meeker and colleagues, this time published in JAMA, looked at 47 primary care practices, almost 250 physicians, and they did a cluster randomized trial where they fed back this prescription rate, and they sent them an email. And I don't remember if this was monthly or weekly, but they said, you're a top performer, you're in the top 10% of clinicians, you didn't write any prescriptions for your 21 acute respiratory infection cases, so good for you. And then said, you're not a top performer. Your inappropriate prescribing rate is 15%. Notice I told you we had 70 and 80% people in ours. And so this was really effective, and I don't think I have the sustainability of that was well maintained. So moving on to nursing homes a little bit, and I have to say I was at CDC mentoring our sort of nursing home infection control expert who had come from the Emory system and came to CDC. She had been there about 5 years as I was sort of transitioning to leave. And we were transitioning the acute care stewardship components to the nursing homes. I kept saying to her, is this based in reality? Can we really expect nursing homes to do this? Maybe, I don't know. And so a lot of engagement with some of the nursing home professional societies and the nursing home medical director professional societies. But the bottom line is it's very equal to what's going on in acute care. And I actually didn't think that it was that important to do stewardship in nursing homes, and I've come a long way since then. And so my phone locked out on me, so we have 4 minutes. Saw someone looking. So why is it important? So I firmly believe that now, I do, that we can't work in this sort of silo mentality. And I come from this public health background, but we published this sort of alert a couple of years ago in the CDC Vital Signs that in order to reduce antibiotic resistance in your facility, you really need to work across facilities and work regionally. And the point here was, as some critical facilities acquire a new resistance problem, they're going to be disseminating this around your region. And the more we communicate to sort of put some intervention in place, the more we'll all be better off in reducing transmission. That's just the point of this slide. And here's just an example. This is from my colleague in Chicago, where they had an outbreak of a really bad, we call this a superbug, a highly resistant Klebsiella pneumoniae. It's got this enzyme that degrades carbapenems. And it looks like a complicated network, but these are all our patients and where they were and where they went. And acute care hospitals are in orange. And the red are these long-term acute care hospitals. And that was the epicenter for their outbreak, the red dot. But I put these arrows to these 3 green dots that are just single long-term care facilities. 30% of their patients had passed through these 3 long-term care facilities and were responsible for propagating the infection to other hospitals and transmission occurring at those long-term care facilities. And finally, just within the Emory healthcare system, we looked at all the Medicare data. And you can do this around the state of Alabama as well. You're all connected. So this is what's called a sociogram. So it's from the perspective of Emory University Hospital. And all the Emory acute care hospitals are in blue. And so the most connected, the hospital that is most connected to everything else is in the 3 o'clock position, and that's Emory University Hospital. And this is not the entire state. This is just 8 counties of the state, the most populous area of the most populous community in Georgia. So after Emory University Hospital is another Emory University Hospital, the Midtown Hospital. But you can see that, we're all, connected. And in fact, some of these nursing homes are more connected to Emory than, other hospitals are for transferring patients. But we can identify the 4 nursing facilities that, admit the most patients to us and work with them with stewardship. And we've started doing that to develop their stewardship programs to try to decrease the amount of C. difficile that's coming into our hospital, readmissions that are coming into our hospital. And I think this interconnection is hopefully going to be a successful partnership. So if you do want the references for long-term care stewardship, I have to say I'm really impressed with the Minnesota Health Department. Has a really nice site. I haven't looked at Alabama to know if they have much available. Nebraska's got a really nice site with a lot of tools. And then Rochester, New York has a really nice site with a lot of tools for nursing homes to use. But I think the pitch I'm trying to make is acute care, you will benefit from working with your close partnered nursing homes on their stewardship activities. So I'm going to end. Has anyone ever listened to Dale Berwick give a talk? Raise your hand if you have. I've done it twice, and the first time I was not in the right frame of mind. Because I worked at CDC, and he was talking about, stuff that, I've been working on for 15, 18 years, and I knew what was right, and I knew the approach, and he was trying to save, millions of lives through HI prevention, and I just didn't hear it. And I just heard him literally yesterday. And, I was moved again. I mean, he's a visionary, I think, with maybe being 3 steps ahead of where the rest of us are and where we want to go. But he's making this case that we need to shift the power back to the patient to accelerate, healthcare delivery and make a cost-effective healthcare environment. And I appreciate what he's saying about that. What matters is not what we think is important; it's what the patient thinks is important. But for the life of me, I have to wrap my head around how that can be applied to stewardship, where the patient-centric approach is give me this antibiotic. And so I haven't gotten there yet. So if you all have any ideas, let me know. I'm sure he's right, and this is where we're all going to be going, is trying to shift the power, the balance of power about delivery of healthcare to the patient's perspective. But I think maybe if we just think about C. difficile as an adverse outcome and colonization with these superbugs as an adverse outcome, that's probably going to be the way. And we need more patient engagement and inpatient stewardship than we're currently doing. So I have nothing else to say, but I appreciate your time. Thank you very much.
Anybody have any questions? All right.
Thanks.
Dr. Fredkin, thank you very much. You are a top performer. And 1 out of 1 presentations, you were on time, so thank you very much. I'm sorry. Ed, you have a question?
I'm just curious. I've had this discussion with our orthopedic surgeons about antibiotic stewardship post-op. And their take on it is their professional organization has not made that as a recommendation. So their concern is that, if they don't prescribe the way the CDC recommends that, they shouldn't after surgery, they're not following the standards of care set forth by their professional organization. And that's a concern of theirs. Is there a discussion? How is that handled at Emory? Have you heard anything?
So the conflict is between the Surgical Professional Society saying one thing and CDC says another?
Yes, yes.
Well, at Emory, it's just all about getting the dose. It's the HICPAC recommendations, which is CDC based. So getting the dose in at the right time and then redosing based on body weight, which is tough to do. And I just, I've been in meetings, that's their focus. Right drug, right timing, and then redosing if they have
Not during surgery, but after surgery.
Oh, stop.
Right, and they're saying that the professional organization doesn't say that, And so if there's a concern if one of their patients gets an infection and they hadn't followed what their professional organization recommended, I didn't know if that was, anybody else had that discussion, and that was just an offhand discussion.
I'm not aware of a conflict between the Big Pack recommendations and is ACS or something with how long the duration of the prophylaxis should be. I'm aware what Big Pack says. I didn't know there was a conflict.
Yeah.
And the elderly people are not dosing past the perioperative time. They don't go for 2 days.
Okay, that helps me.
Sure.
I was just going to say in regards to shifting the power to the patient for antimicrobial stewardship, I'm a pharmacist at the VA, and we've been meeting with providers about acute respiratory infections. And one of the things we've been recommending is a shared decision-making tool where you discuss like what is most concerning to the patient and try to address that particular symptom and get them on board with symptom control rather than antibiotics.
Is that an outpatient setting?
Yes. Well, outpatient, I mean, we meet with both types of providers, but yes, specifically for that, outpatient.
Thank you. I'm curious if there's a version of that for inpatient or not.
Yeah, I mean, I think it can apply also.
Thank you. Any other? Thank you.